This is a Floating Voter Budget Special in association with EY Ireland. Hello, I'm Kevin Doyle and this is the Floating Voter Special in association with EY. Last week on the podcast we had Finance Minister Paschal Donhoe telling us about a budget that he said gave us reasons to be hopeful for the period ahead. This week we're back in a national lockdown. Nursing homes are back on the front page. The contact tracing system has had a serious wobble and let at least 10,000 people slip through the net. And the national mood is not one that would reflect the bank holiday weekend. I'm joined as always by I&M political editor Philip Bryan. And to give us the most up-to-date situation on the frontline battle against COVID-19, we're delighted to have the CEO of the HSE, Paul Reid. Paul, you're very welcome to the Floating Voter.
Morning, Kevin. How are you doing?
Good. It's a tough job at the best of times, but I'm looking through the papers again today and there's a real sense of deja vu. Nursing homes on the front of all the broadsheets, fears of second waves. And I suppose that the standout story is that story of the last 24 hours, the Nightingale Nursing Home in Galway. Were the staff and the residents there abandoned by the HSE as they have claimed?
Well, I think first of all, you stand back and take everything in context. So what we are dealing with now is certainly a rapidly escalating situation in terms of the virus, massive transmission in the community, and putting a lot of things at stake, including how do we protect nursing homes and how do we continue to scale up with testing and tracing process to stay with that level of increased demand. So that's what's happening. Just specifically in relation to the nursing home and the one in Galway, I think we've communicated out yesterday. Once we were alerted on Sunday, which was a positive admission to a hospital, we immediately carried out mass testing of the nursing home on the Monday and immediately mobilised some support to help in terms of infection prevention and control, and also some other supports. And throughout that week, then in terms of resourcing and working with the nursing home. So from our perspective, we were in as quickly as we possibly could. We carried out the testing as quickly as we possibly could, and we've been supporting the nursing home throughout this week. I suppose, though, when you look at it on the bare facts of it, the idea that for any period there was 20 or so residents left with 2 or 3, I know there's variances about the number of staff that are said to have been there, but that ratio, just to anybody looking in at it, 20 people thereabouts that were sick with COVID left with 2 or 3 staff looking after them. It's an impossible situation. Well, there's a few aspects to it, and I can't really go into all of that nursing home one in particular, because we're still working quite intensively behind our side with them to get what may have emerged. But we've been saying this very clearly. When this virus gets into older and congregated settings, it transmits rapidly and quickly. Now, the protections that we have been doing is carrying out serial testing, both of staff and in many cases when there's an outbreak, residents as well. But it is a function of once it gets into a nursing home, it transmits absolutely rapidly. And there are important infection prevention controls that the nursing home need to put in place, but it is high risk once it gets in.
Can I just ask on that, Paul, on the infections controls that the nursing homes themselves have to put in place? Because I think that gets a little bit lost in the argument that it's almost forgotten that, especially when it's a private nursing home, there's a responsibility there on the owners who are receiving the money from quite large amounts of money from residents to put their protections in place as well, to find the additional agency staff, to find whatever resources are needed, rather than to wholly have to rely on the HSE. That's a fair point, is it not?
Yeah, and especially when you're in a situation like that, where I'm never going to go as a blame game. And in fairness to Ty Daly from Nursing Homes Ireland, he hasn't either. But just to put in context, throughout the pandemic, the supports that we have been providing to 80% of the nursing homes are privately owned nursing homes, privately managed and privately owned nursing homes. And from our perspective, we've been providing a range of supports. So PPE on a weekly basis. We've now distributed about 46 million, somewhere between 46 million and 50 million of PPE to nursing homes. We've provided, government have provided, we've administered the temporary assistance payment scheme, probably close to between 50 and 60 million of supports. 60% of that has been drawn down or utilised in terms of staffing. And a wide range of supports that we have been continuously running with nursing homes. So there is an obligation on all of us, private nursing homes, to work with us, for us to work with them. But responsibilities are on a daily basis with this virus in terms of how it gets in and how quickly you act as well.
I know you don't want to play the blame game, Paul, but does it frustrate you then, because the HSE almost invariably gets blamed when situations arise? So does it frustrate you then that you always get the blame?
To be honest, no, and I do mean that, because the first thing you think of is the residents, and you think of the vulnerable people in there, and you say what can be done, and I do mean that. It's there's many personal frustrations you get in this role and my role, but I try to stand away from and just say, who are we trying to protect here, and what needs to be done. I mean, it does come back to a more, in my view, a more strategic look at the whole, and the expert panel has looked at this, the whole strategic oversight, governance, direction for the future for nursing homes. And our big strategic questions in there, which the expert panel, I think, did really well on nailing.
Then I suppose, look, the front of our own paper this morning, the headline is "Fears of Second Wave in Nursing Homes." It talks about the level of community transmission that's out there at the moment, and that makes it very difficult to keep COVID out of care settings. Like, can you, given that the insight I suppose you have, and you see all the data that comes through every day, and you know what the situation on the ground is, like, is there any assurances you can offer people that we won't have a second wave, that maybe not as bad as March and April, but something close to it?
Well, certainly what we can say is we are, first of all, a lot more learnings from the first phase, both in terms of the transmission of the virus and how it transmits rapidly and quickly in congregate settings and elderly people. Secondly, the wide range of provisions and supports that's been put in since the first phase and to now, and I just touched on some of them there, so I won't go through them again. So thirdly, the serial testing does give us, in many cases, an early alert or an early warning system. But on absolute assurances, no, we can't, because if you go back to the expert panel or even just our own analysis, we tried to do an assessment of, was it worse in the first phase of private versus public, or was it worse in terms of newly, well-built, well-furnished, well-equipped new nursing homes, or was it back to older, more traditional congregated Nightingale kind of wards, or what was it? And the strongest linkage you can draw back to is actually probably none of them at all. It's back to the community, where it was highly prevalent in the community. You had a direct line in to nursing homes in that area, whether they were private, public, small, big, large, new, old. So it does go back to your question of...
When the figures were broken down, there was no real difference in, like you say, in a new nursing home, the outbreak in a new nursing home or an older one or public-private. There was nothing pointed towards, like, if it was state-of-the-art, brand new, great wards, you have less of a chance of catching it or having an outbreak.
No, actually, on the contrary, there might have been some exceptions where you say, how did that happen over there? But the strongest linkage you could bring back to was where it was highly prevalent in the community. Various kind of nursing homes were hit hard,
So you must be very worried then, looking at the figures, the 14-day incidence rate, places like Cavan, where it's absolutely off the charts, over, I think, 1,000, the incident rate of over 1,000 per 100,000. You must be really worried when you see those stats. And I know we're gone into full lockdown now, but we are, in terms of daily figures, as bad as we were at the height of this.
We are at daily figures as well as, yes, our daily figures are, so just take the figures first. We start the year in extremely high levels where we were at the start. Positivity levels may not be as high, but equally we're testing much higher volumes than we were at the start. So, we're all trying to just get our head around the correlation between now and the end, but certainly we're doing higher volumes, mass testing, serial testing. There's a whole different set of suites in place. But bottom line is, yes, higher community transmission levels all across the country. particularly where you see the high prominence in cabin and others.
So
put congregated
just
settings.
one thing on the nursing homes that I saw alluded to today, that is the HSE in some respects competing with the private nursing home sector for staff? I saw that mentioned, as in like obviously once there's a high rate of community transmission, especially among healthcare workers, that means more agency staffs and things have to be deployed. So how do you fix that challenge? How do you address that when you're all jumping in for the same resources to fix the same problem?
Well, if you stand above it all, there's no doubt here globally, everybody's chasing healthcare workers, particularly nursing and home care workers. So there's a big demand for them, that's for sure. Secondly, and we are in the HSE is in a high level of recruitment mode. Thirdly, what we are doing, and we've written more letters about this to our own internal teams and elsewhere, we don't want to be cannibalising the sector, and we're making as much protection as we can. But there is a basic rights of employees and the public in terms of applying for these jobs, putting themselves forward, and not being barred from them. So we do work to try to see where someone gets through, how we can hold that period of recruitment for a sustainable period of time. So we are doing whatever we can, but we can't stop people applying. That's what. And certainly,
what's the difference in? I mean, look, it comes down to working conditions and pay, really, doesn't it? Mostly, anyone going for a job. Like, what's the difference in what the HSE offers? Say a standard nurse versus what someone in a private setting might be offered?
Yeah, I don't have, to be frank, the pay rates in front of me, but there is no doubt if you apply for HSE, it's permanent pensionable job and more sustainable rates, and indeed extra routes of promotion and variety. So that's the facts. So they certainly would be more attractive, I've no doubt, to employees in private home care sectors. Now, there hasn't been a huge deluge, I have to say, of home care staff coming into the HSE. We haven't seen a massive flood of it, and I don't think they've seen a massive loss either. But there is the factor about a reluctance of healthcare workers, agency staff, going into private nursing homes, and that's just a fact. We saw it in the first phase, we can see it now, and there is a challenge for me to if you look at the supports, which you could probably call horizontal, which is HSE into nursing homes, there is a vertical demand, and we've been saying this to Nursing Homes Ireland, within the private nursing homes to provide supports within nursing homes themselves.
Yeah, I guess just to pick up on that, it is tough to ask somebody to go into a home where they know that there is maybe 80-90% of people there have COVID, they're COVID free, and they have to go home to their family. It's a very big ask of someone who isn't on massive money. Yeah,
it's a big ask, but the infection prevention controls that we do put in place, they work. They work as we've identified case. They work in terms of protecting our staff. The issue is how do you just have that working all of the time relentlessly, and that's the demand now in these nursing homes and ourselves. Infection prevention control. It's 24/7. You can't let your guard down for 1 second.
Just then, finally, on this one, the Ireland's Call programme back in May or thereabouts, it didn't really amount to much in the end, did it? All we ever hear about is people who applied for it and didn't actually get a job.
Well, the straight answer to it is if you see the numbers that have been recruited from it versus the numbers that applied, yes, there was a marginal uptake in it. Now, it's been a huge overhead for us to go through all of those numbers. So if you take it at the top level, 70,000 applied, more than half of those, we wanted people who can add value in healthcare workers. It's not just a call centre running. We wanted people who can go in and help on Frontline. And over half immediately just weren't in scope in terms of adding value to that. As we got into a lot of the interview processes, people were putting their name forward in good faith, wanting to help out, but actually then either reverted back to their own job or just weren't interested. And then when we went through the interviews, particularly for some people who are a lot more qualified, huge drop off. And again, back to the first phase where we were dealing with high outbreaks and high contagion of the virus.
They dropped off themselves personally?
Oh yeah. We've huge personal dropouts, offers of roles drop off at various stages of the process, including offers.
Presumably,
of roles.
when they saw the escalating situation, they thought maybe
Yeah, and that was back now the first phase. But even now, as we've gone through it, in terms of contact tracing, gone through a lot of that. Now you're finding a lot of people back doing their jobs, and so it was a process that galvanised the nation, put forward, but the outcome of it, has been marginal. Yeah, and the numbers of contracts we've offered versus the numbers are taken up.
What type of percentage would you say?
It varies between professional or medical or clinical grades, but I would say probably 5 times to 1 for job offers that we've made is taken up.
I suppose if you're saying there was a big overhead, obviously, to do the HR side of all of that, if you were to do, I suppose, learnings and a cost benefit analysis, then it wasn't really worth it, was it?
Well, look, there's been many learnings from the first phase, and I've been open and public about them. Myself, between private hospitals, nursing homes, and certainly the overhead that we've put in. It was good. Actually, I think there's been a value in it, and just galvanising the nation at a point in time. People making.
So it was a PR exercise then.
I know. Well, it wasn't on our part because it was a really massive call quickly. What can we get? But I do think
on the government's part, then it was a PR exercise.
Yeah, man, I don't believe so. I think it was. If you have to cast our mind back to March, everybody was scared, and we were scared about what was coming at the hospital system, and we were scared how we would cope. And certainly the primary intention of it was nurses, medics, put up your hand, come back, answer Ireland's call. So that was the primary driver.
What was it like in some of those meetings, Paul, though, at the start, when you saw the situation evolving, when you saw the numbers going up, when you saw that the rates were going to hit so hard in the hospitals, the ICUs? Like, what was the mood in the room when you were having those initial meetings? You're obviously not an MFIT, but you were sitting in the room with the health minister of the time and the Taoiseach at the time. Yeah. It must have been just pure dread and fear.
Yeah, I mean, people will always remember certain dates, the first case, the end of February, the lockdown dates. But for me, we go back to the 3rd week in January. I convened the first meeting of the crisis management team on the Sunday, I think it was Sunday 27th of January, it's sticking in my mind. It might have been the Monday we actually called, but we had a phone call around on the Sunday. And that was purely just by what we were seeing throughout January, literally the wave coming closer and closer across Europe, seeing emerging of it. So that was the first meeting. And then, and even when you think back then, the decisions we were making, how many ventilators do we have, how many ICU beds, what PPE do we have? Just think back then, 27 January, we spent €15 million on PPE. And then someone saying, we need to double it. And I'm going, double it? Yeah, 30, yeah, double it. And now we're at over $1 billion.
That's striking, really, because I don't think, and it may have been on your mind and other people's mind, but I don't think on the 27th of January has really hit home with the public as such.
Yeah, and look, we've had, and from the 27th of January, we probably had 3 crisis management meetings a week.
And who are we talking about there? The Taoiseach, the health minister, the CMO?
No, sorry, that is the HSE. That's the HSE crisis management team. And I think NEFID were engaged on the same day, I think it's 27th or 28th of January as well. And then obviously, cabinet committees. And
did we move fast enough then, really, at the start? Given that you guys, you seem to be prepared fairly early, and then the lockdown didn't come to the 16th of March, early, a month and a half later.
Yeah, it's a difficult call, but certainly the sense, it's hard to track back the dates up to the 16th of March, but the sense of the 10 days before that was really when to go, what was happening, should we go now, should we wait later? But that was the kind of build up to that, and I remember on the night the Taoiseach was away, obviously in the States, and as part of his.
And did you get, just in that vein, did you get a similar feeling, say, last Saturday afternoon when you were sitting in government buildings with the ministers and the CMO that, look, we're back to where we were in March?
similar but different. I mean, a lot more knowledgeable about it now. A lot more assessment of and a lot more clarity a lot more realization that there's no guarantees from this. There's no guarantees that, you do this and you get Y, whereas the first phase, it was just in some way easier. We just have to do this quickly. But we've a lot more learning from it, and we've a lot more understanding of the benefits and the impacts of lockdown. And certainly, from a health perspective, that's one of the things that's been on my mind, and that's one of the that's as you've all been important. That for me was one of the stronger points of last weekend. That we did get a sense of all of the wider economic impacts, all of the sector impacts, and we have been at the oversight committee for a number of weeks.
There was a presentation when Eamon Ryan walked out of the building on Saturday evening. He gave the impression that he wasn't overly concerned. Like, there was concerns about the ICU capacity, the bed capacity, but he didn't strike me as someone who was, had been shocked off his seat into a national lockdown. But that was from your presentation. And I think, like, even the week earlier, you tweeted something about after the first level 5 recommendation, that even at that stage as well, you really thought the health service could deal with the capacity of what has been coming.
Yeah. Well, look, I've been very open and public throughout this for the past few weeks, just about where we are, and certainly even on our Thursday press conference, and I'll just relay it down to the Saturday, but on our Thursday press conference, I said the same again, that we were coping, challenged but coping, but concerned about what might look forward ahead in the coming weeks. And certainly my message, my input last weekend was around, yes, coping. And I don't make those judgments myself. That was based on calls to many of our clinical leads, our hospital group CEOs, CHOs. So, coping, challenged, equally concerned about the community transmission, what that may translate into, rising hospitalizations, and the lag that may mean in terms of ICU.
But I get the feeling you weren't one of the ones who were pushing for the level 5. Doesn't feel like you had your finger on the DEFCON 1 button.
Yeah. I know, because, well, look, we all come to this at different perspectives, and I've been listening strongly a lot to our medics, our clinical guys, about some of the wider impacts, from the first phase. So some of the impacts in terms of people not coming forward for care, people coming forward much later in terms of time critical care, and needing more interventions and higher risk interventions. Secondly, mental health, anxiety, stress issues, elderly, young population. Thirdly, pediatrics. We did a pediatrics report on the impacts of young children during the first phase. RCSI and ourselves co-sponsored. We're doing an assessment of impact on elderly people during the phase. Not just a lockdown, but during the pandemic. And I have all of those in my head, so, I'd obviously come at a different perspective. So that's the balanced perspective I come at it. Now, to say it straight, the outcome and I've always, and myself and the board of HSE, we've kind of said, let NEFIT do the analysis and work level we should be at. Let government make the decision, and we just play it straight back where we are at any point in time. And that's really what I meant by my tweets and everything else. It's that, there's wider considerations here as well,
I suppose on those wider considerations, like we've seen other countries have done studies on the non-COVID mortality rates during this period. Have the HSE done anything? Have you any information in that area in terms of people who died from cancers or other infections or heart disease that may not have? And I know it's a game of may and may not, but statistically, I'm sure you can look back at previous years.
Yeah, and there's some analysis, as you say, emerging from Europe, just in terms of critical care interventions, oncology, cardio, and that we don't have a depth of analysis on it just now. It is something with the colleges and others. Where, as I said, we've done pediatrics. We're looking at older care. We're going to look at some of the other issues of care, but it's hard to draw a direct correlation to it. I'd certainly say the fact that we ceased all all other care, bar non-urgent care in the first phase, is a big learning for you. And it wasn't just ourselves; it was WHO as well. I think that's been a big learning because there just has to be something.
It was. I understand why it happened, but it was atrocious in some ways. In hindsight, to think that happened, and the waiting list that you're going to be dealing with now, whenever this calms down, for the entire tenure as your time at the top of the HSE, you're going to be facing questions about waiting lists, because we're not going to get on top of them for years and years and years.
Well, it was, but again, this is going back to, we're looking back now in hindsight with a lot of things, but put ourselves back in that frame of mind. We saw hospitals overwhelmed, and we saw the devastation in Lombardy and coming through in Spain and France and right on our door. And the scare was protecting anybody who walks inside of a hospital that doesn't need to be in it, So that was rationale, and I understand that, and that was rationale then. Now, it's still a high risk now, because I know we're talking about this morning, 300 we're probably back to about 306 this morning of hospitalised cases. And what I have been saying to Cabinet is, while we're doing lower numbers and we're coping, it has a disproportionate impact. 5 COVID patients has a disproportionate impact, and maybe 10 other patients does, because all of the infection prevention control they have to do, closing off, sealing off wards, beds, it has a disproportionate
Do you think
impact.
we're going to get a private hospital deal next time around? I know there's a lot of resistance. They don't act as a group this time. They want to do their own thing, and possibly the last time. And again, we were kind of on a war footing, like you say, so it didn't really work out as planned, and probably wasn't great use of resources. But do you see a role for them in a second wave? Or
I see a role and a need for them. And I'd say we've 2 legs of a 3-legged stool put together, and the 3rd leg is going to be key. So we have transition funding of 25 million, which we're drawing down at the minute with them. We have the procurement agreement, and we're doing some mini procurement deals with them at the moment, and that's largely about geography and what services are needed. And then the 3rd one is exactly as you say, the kind of the safety net agreement, we would call it, which is about a massive surge arises, and how we would work with them and the demand on them and us. That's not a very tricky phase. They certainly, firstly, they want to do it all individually. That's fine with us. We understand. We'll do that. Secondly, some of them had said that their boards are, and they have private boards, that they are, not inclined, and that will be concern. And thirdly, we definitely see a need for them.
I think you should name and shame the people whose boards are resisting playing part of the national effort. You probably won't, though.
You guys are probably better narrowing those things down than I am. But they look. I still would be confident we'll come to an arrangement, and if there's a few outliers, we'll see where we are then. But I think we're making progress with a good lot, to be frank. And I think we'll then see where we are.
Paul, can you tell me what's the pressure of the job like when you're looking at those daily figures? When you see the case numbers knocking up, when you see deaths, like there was 13 the other day. Like, how do you deal with that? It's a lot of pressure, like not just on you, but obviously there's a small group of you, possibly that group that met in Dublin big government buildings last weekend, who have the weight of the country on your shoulders.
Oh yeah, so if you take it, I'll answer you separately at a personal level, but yeah, across a range of us who are dealing with this, like the first lens I have is to my own team, and we have genuinely been at this since the 27th of January, and very few of us have had a summer break, and that's just so. At a professional level, on a management leadership level, I have to watch out for my own team because it's been relentless for them. Across the kind of wider sector between ourselves and NEFID, it is relentless, and there's no easy calls on it, and there's no direct correlation. If you do X, Y will happen. That's the kind of grey space that we are operating in. And I guess the biggest pressure point emerges from people wanting absolute clarity, and not just the public, and sometimes our politicians want them. Tell me X, and we're in the grey space, which is more difficult, So it's hard. Like your question, can we give absolute assurances on nursing homes? No, we can't. Here's what we do in the middle. So that for me is more the pressure point. It's just you're operating in a grey space a lot of the time, most of the time.
You were the chief executive of Fingal County Council beforehand. I suppose a different beast in some ways, quite political can be as well, but you can't imagine, you would have known coming into the HSE role, and we know it's not exactly a role that people are fighting to get, because history suggests that you're just going to get flogged for your entire time there.
To be a sadomasochist.
You can't have imagined, but you can't have imagined when you took it on that you would be dealing with this type of a crisis, and that everything that comes after this now is a crisis. The HSE is perpetually in crisis, but nothing like this, and this is going to have such a long-term impact afterwards as well. It's not the job you signed up for, is it?
Yeah. Well, there's I've said this to somebody before a few times maybe, but I'm never quite sure whether I follow crisis or crisis follows me, because most of
oh Jesus.
I've been dealing with in all jobs. When I was in Aircom, we used to deal with storm damage, and that was a big crisis, and every time there was a storm you were in crisis management mode, and there was many crises in Aircom in my day, because I went through 6 different strategic ownerships of the organisation, and 6 different boards, and 6 different CEOs, and so anyway, that's just
by the time you leave the HSE, you'll probably have gone through 6 different future of healthcare plans.
Well, in my limited time in public service, which I think is 2011 to now, so 9 years, I think I've worked through maybe probably 8 ministers and 3 governments, 4 governments.
But you're well used to politics. You have your own background in politics yourself, do you not?
Yeah, I did. In my early days, I was an active member of Prunchia's Ross's team in Workers' Party in Finglas, and a great time actually. Party was very active in working class, and grew a number of seats very quickly.
Did you run yourself at one point?
No, I didn't actually. I'll tell you now, I had a nomination and I was just about to do it, and I bottled it. I was a very young, just married man at the time, and
as a councillor, or was it for a council seat or a Dáil?
No, it would be in one of the general elections actually. A nomination put forward, and I think it was probably, you can work back. I got married in '85, so I think it was probably just about then. So whatever the election.
The middle was that was the messy part. The 3 little elections in 4 years, was it?
Yeah. I can't remember which one of those. So no, I didn't.
And was it your wife talked you out of that, Paul?
No. And in fairness, if she was talking me out of anything, she probably would have talked me out of this one. But,
well, that's where I was going to go with that question. Was if she talked you out of politics, but not the HSE?
No, she didn't. And in fairness, I just say it now for the record, she has supported me in whatever I've done, and I could never have done anything, whatever. So no is a straight answer. But getting back to your question on. Sorry, back to your question on this one, I kind of missed 2 of them, the pressure one, but getting back to this job, I often reflect, certainly as I signed up to it, I knew, 2 things. I signed up for a contract for 5 years, and that is really the good lens that I want to have on jobs, because, I determine Fingal, and it gives me a great focus to get things done. And so that's what I signed up for. I'm very anxious with the reform agenda. Very interested with the reform agenda, and wanted to get in and not just run the system, but change the system. And actually, as I do reflect on this, I think we've implemented more change in the health system in the last 6 months than we probably would have had the opportunity to do in probably the next 6 years. And I'm not saying it's transformed, because it's not, but we've implemented many initiatives that has demonstrated to us ourselves, the health system, and given confidence to the health system about what we can do differently
But what are the permanent changes that will stay? Because we're all seeing it in all our workplaces and wondering, will it slip back to the old ways?
Yeah.
Are there reforms that you have done that you will confidently say, when this all passes, that's something we should have done, we did it, and it'll stay that way?
Yeah. Well, I think the first one is getting us out of this lens of the acute hospital system. And, it'll be our discussion today, how are we doing in beds and how are we doing in ICU. But actually, we have shifted and made a belief system in the HSE that the biggest way you can help the hospital system is get your primary care and get your community services and your social care services working better. That's number one. And secondly, have the two organisations working better aligned. So in terms of what's been there that I think will see us through better, first of all, a much better working processes and role for GPs working with the HSE and the healthcare system. They're in the process, they're not outside of it. And I think that's been great credit to how they've worked with us. Things now that our hospital system are doing themselves, like having outpatients clinics, not in the hospital system, but outside of the hospital system. There's a lot of those happening now in primary care centres or just generally outside in other locations. And I think that's more sustainable for the future. I think there's a stronger awareness from GPs and pharmacists and general practitioners in general and primary care to not have the first port of call to be the emergency department. Now, how do we sustain all of those for the future, and even in the public psyche to think about?
Is that one of the positives that COVID has given us, is that people are kind of a little bit more reluctant to go to near hospitals now because there's fear of the spread or the fear of the virus, and it's obviously a little bit safer to go to your local GP or primary care centre.
Yeah, as long as it's the latter, exactly, Philip. As long as that would be my concern, that people are just afraid to come into the hospitals, and that's not good for anybody. But if the mind has shifted, which I think it has in a lot, check with your GP first. So whether that's through fear, I'd say a lot of it is through fear. But if we can sustain that kind of way of the public thinking of primary care, GP care first. Now, a lot of people don't have GPs. My first 6 months in this job, I spent a lot of time out and about. But even in emergency departments, I just generally talk to patients and just say, how and chat. And a lot of them didn't have GPs. People went to a lot of working class areas, particularly a lot of non-Irish population. They actually, a lot of them don't have GPs and don't have access to GPs. So
it's hard to get on lists these days. It's very hard. There was a situation, I think, at one point during the pandemic where, you were supposed to go to your GP to get a test, but then I know a situation myself, like trying to ring around every GP and doctor in Dublin, trying to get onto the list to get forward for a GP, but all the lists were full up at the time.
No, and that's kind of getting back to some of the strategic issues, not just on HSE, but getting a better pipeline of GPs coming through. It's improving, but that's a really big issue for us too.
I want to just touch on one other thing before we finish up, because we kind of skipped over it, but I think it's important to come back to, even though I know you've done a couple of interviews about it already. But the contract tracing system, I know you said you can't give any guarantees around nursing homes, but can you guarantee that the contract tracing system will be able to stand up to demand in the weeks and months ahead?
Well, I tell you, this is a really big operation now, right? And I spent most of my time this morning in calls with it. And a process on an operation like this, in normal times, takes a sustainable period to build, right? And we have been building it mid-flight, as I've always been saying. And we've been recruiting, and we're putting in a new model. So the one thing I want to make sure in terms of this model is, firstly, that we have it resourced effectively. Secondly, that there is value for money in it. Sorry, we utilise government funds wisely and utilise it well. Thirdly, that we put in place automation. It's not just about throwing resource at it, because you have to give the public a better experience and a quicker experience. So we're doing all of those in parallel. And looking forward, if you look back over the last few weeks, one of our biggest challenges was building capacity. And we had, you know, when are you going to hit 200,000? When are you going to hit 100,000? Which was never a target. It was a capacity. And now we've reached it, and now we've achieved it, and now we're above it. But certainly our pinch point in the last couple of weeks has been the tracing aspect of it. Right? And we mobilised a lot of resources into it. And we can certainly cope with the numbers that's coming now. But you have to think, when that goes from, which it did on the 8th of October, from 500 to 1,000, it didn't go from 500 to 700 or 800. It went 500 to 1,000 and over 1,000 practically every day since. If it goes from 1,200 to 2,500, that's a big stress on the system, and you can't just have a massive switch. So the risk for me is getting it under control in the community. We are mobilising effectively to deal with what we're seeing coming at us, or what we're modelling coming at us, and that's what we'll do. But in any big operation, there's going to be decisions we have to make. Like if you just think back a few weeks ago, there was a very big political reaction to us to having moving resource from the serial testing of meat plants into community swabbing. That's absolutely the right thing to do, and there are operation calls you have to make. So the squeeze point has moved along this at different stages. Firstly, it's been swabbing. Secondly, it's been capacity of labs. And now it's in terms of tracing. I'm confident the numbers that we're putting on it is addressing the problem we have right now. But the high risk of contagion means there is a level, I think Tony Hilton was talking about this last night, there is a level of community transmission that puts every health system, and has put every health system, both in terms of testing, tracing, and capacity under stress.
Last one before we wrap up, but you're obviously getting your biggest budget ever for 2021. But what, in terms of planning, and I'm sure you're trying to predict the piece of string question, but how much longer do you think before the crisis settles down? Because there was a time when it started that we were told if we can get this under control in the summer, we'll be grand, and by November we thought now that we'd be coming out the other side of it. Now people are saying, oh, well, if we can get through the winter and get to spring, but actually, sure, it started in spring, so there's no guarantee that in March, April, we're not seeing another spike. I mean, what's the trajectory here as best you guys can see it? When's it going to end, basically?
Yeah. Well, we are definitely, from a financial perspective, which we have to do, we're definitely planning for this throughout 2021. So our budget has been the budget from government, and we're doing our service plan now very shortly. We have to plan for the capacity that we put in place, both in terms of acute capacity, community capacity, testing, tracing, PPE. We have to plan for that to run throughout 2021, and that's what we're doing. So that's our lens to plan for this to run through 2021. If you stand back, what might change that? If a vaccine emerges, and we're obviously engaged with the EU partners and the advanced purchase agreements that will emerge between ourselves and Europe, and the distribution of the population distribution of a vaccine, how that may emerge is all being worked through.
Okay, well, I suppose we'll all be hoping and waiting on that vaccine, and it'll be interesting to see how it's distributed when it does come. But that is our lot for this special Floating Voter episode in association with EY. My thanks to Philip Ryan, as always, and to the CEO of the HSE, the man with arguably the hardest job in Ireland at the moment, Paul Reid, for joining us this week and talking us through some of the various crises that he's facing.
You've been listening to a Floating Voter budget special in association with EY Ireland.